Hello, everybody, and welcome to our PrecisCa tumor board on multiple myeloma. Very excited about these cases and our panel. I'm Dan Pollier from the University of Colorado, and I'm joined by a really great group of colleagues here today to discuss these cases. And so each of us is going to introduce ourselves, starting with Dr. David Schuster.
Hi, I'm David Schuster. I am a radiologist and nuclear medicine physician from Emory University.
Hi, I'm Dr. Peter Forsberg. I'm a medical oncologist with a specialty in multiple myeloma at the University of Colorado.
My name is Ajay Nuka. I'm an associate professor at the Emory University Winship Cancer Institute. I specialize in multiple myeloma.
This is a 65-year-old male Jehovah's Witness with an IgA kappa restricted multiple myeloma undergoing evaluation for autologous stem cell transplant. And maybe I'll just pause before we even get to the question and ask Dr. Forsberg. This is the first non-IgG myeloma, I believe, that we've discussed. And what comes to mind when you think about things like IgA myelomas? How do you think of them differently, if at all?
So I think it's a good question. It's one that often patients think about as well. When they're categorizing their myeloma, they often think of what we call isotype. So those, that's IgG, IgA, occasionally IgM, kappa, or lambda free light chain alone. Between those, there's not a huge amount of differences necessarily. IgA does have a bit of a potential to be a little more aggressive than some of the other types. Myeloma that has major light chain, sort of free light chain components, if it's, just kappa or lambda free light chain, or, one that has an intact immunoglobulin like an IgG with a kappa or lambda, maybe at a little higher risk for renal involvement. IgM myeloma, it almost always has a bone involvement. So there are some slight differences, in terms of manifestations based on subtype, but for the most part, they're more similar than they are different in terms of their characteristics. There are sometimes things that are a little more challenging in terms of how you measure them over time. Measuring IgA myeloma requires sometimes that, monoclonal proteins on SPEP don't migrate as well, because of characteristics of it. You may get it into the beta region as opposed to the gamma region. So often with IgA, we may measure it more consistently with quantitative IgA levels. But there are some unique characteristics in how you may monitor different disease types, but more similarities than differences between those isotype types.
Great, thank you. So we're going to discuss a unique challenge for the folks like us who deal with hematologic malignancies when we encounter patients who are Jehovah's Witnesses, which is a type of Christianity in which many adherents will not allow for the receipt of blood or blood products. And having taken care of patients such as this in my area, I know there's a wide amount of variation in patients' beliefs and what they will and won't accept. And as you can see in this case, this is a Jehovah's Witness patient who is willing to undergo an autologous stem cell transplant. But as we'll learn, not any other type of blood products or any donor blood products. And so we're going to discuss this very challenging situation that we encounter. So this patient presents with anemia, performance status of 1. This patient has a history of chronic kidney disease and is a former smoker with no alcohol or illicit drug use. And as a Jehovah's Witness, this patient does not allow for the receipt of donor blood products. No family history of cancer. So more specifically, March of 2021, patient has a serum protein electrophoresis that shows a monoclonal protein of 3 grams per deciliter of the IgA kappa subtype. MRI of the entire spine shows a T9 lesion. Apparently this patient is asymptomatic, or at least we didn't hear that there's any pain associated with this. Bone marrow biopsy is normocellular, 50%, but near replacement by these kappa-restricted plasma cells. Cytogenetics was not performed, as we've heard Many times metaphase cytogenetics doesn't grow in multiple myeloma, but certainly FISH is always recommended. This patient underwent kyphoplasty at the T9 level. Biopsy at that time did show multiple myeloma. A PET-CT, which we don't have images of, show lytic hypermetabolic lesions in the left humeral neck and the proximal shaft. The T9 kyphoplasty area was seen. And then also dental disease with hypermetabolism of the lower right molars. Dr. Schuster, can you tell us, is this something that you typically see or comment on, dental manifestations of disease or just dental observations in PET scans? It's not something I'm too familiar with hearing about.
Yeah, so this is considered a quite common incidental finding. The FDG is exquisitely sensitive to any type of inflammation. So in general, I think it depends on the extent. It's fair game to mention it as an incidental. I think if there is significant, it may raise some questions, such as should the dental disease be taken care of before you start a course of additional systemic therapy, et cetera, et cetera. But it is a very, very common finding.
Got it. So this wording or language such as this, again, I know we're not letting you see the images, so we should not assume that this is involvement of the jaw or anything like that. This is
correct. I think common things are common. I think it might be worth looking closely, obviously, at the jaw. But if these are isolated to the sockets and there's no expansile lucid lesion, then this is dental disease.
great. Okay, thank you for that. So in April 2021, the patient initiates lenalidomide, bortezomib, and dexamethasone. So, first, just backing up for a second, Dr. Nuka, aside from the fact that this patient, the Jehovah's Witness issue, which we'll get to, do you agree with this initial treatment recommendation for a patient with this disease as described?
Absolutely. So none of the treatments that we use are cytotoxic treatments upfront in the induction setting. So that fluctuations that we see with the cytotoxic treatments are not what you see with the induction regimens in myeloma. Even with the 3-drug regimens with lenalidomide, bortezomib, dexamethasone, and now with more emphasis or the push towards using the 4-drug regimens, using the CD38 antibody upfront, as shown in the Griffin trial, and has reached the NCCN guidelines as well. These are all showing that the benefit of achieving those depths of responses earlier in the course. The likelihood of anybody needing a transfusion during the induction period is almost extremely rare, very negligible. It's in fact the opposite way. When myeloma causes the end organ damages as a form of anemia, the treatment in fact helps overcome the anemia. So we'll be seeing there's no absolute contraindication to using any of the treatments in a Jehovah's Witness patient as we used in any other patient. And
Dr. Forsberg, this is good information to know. This is the standard approach, and it applies to a patient with Jehovah's who would not accept a blood transfusion. Would you do anything different, such as use an erythroid stimulating agent or anything like that that you would do or not?
Yeah, I think it really depends on the extent of anemia that they're experiencing. I think you'd probably have a lower threshold to use an erythropoietin stimulating agent than you would in a regular myeloma patient. But I don't know that you'd a priori begin to use it in somebody who has relatively preserved hemoglobin, with the start of these agents, because as Dr. Nuka mentioned, we do deal with anemia as a common scenario, but often the treatment helps to improve it. So, we may end up with a tight window during your very beginning of treatment. If a patient's going to need transfusion support, often you'll know it right away. If they needed transfusion support at time of diagnosis because they were so anemic from their marrow involvement. But it is somebody where you would certainly have a lower threshold for an ESA than you would in somebody, you may have a hemoglobin threshold of 10 as opposed to 9 or 8. So I certainly would probably have a slightly different trigger for that, but I wouldn't necessarily initiate it if we were starting from a relatively preserved hemoglobin at baseline.
Got it.
A small caveat to this. So
Yes.
if we're using the ESAs up front, I would use more than an aspirin for thromboprophylaxis when patients are receiving lenalidomide.
That's so just more to that point. So the extra risk of thromboembolic events with an IMiD plus now an erythroid stimulating agent would make you use a stronger anticoagulant.
Yeah, anything depends on the DOAC versus low molecular weight heparin versus warfarin, but it should be
something beyond aspirin. Okay, I think it's a really good point to bring up, because that would be now multiple risk factors for a clot, and I think warrants more attention. So thanks for bringing that up. And then Dr. Forsberg, I mean, do you have any experience with some of these centers that specialize in bloodless autologous stem cell transplants? I don't know how many there are that do this.
Yeah, to my knowledge, there are not many, but it is something that is a consideration. I think that, I think every circumstance should be considered individually. I think that that's true for transplant writ large, for a therapy that's as intensive and that has potential for high risk side effects as an autologous stem cell transplant. And so I haven't necessarily, I haven't had direct, working relations with any of the, sort of more developed bloodless transplant centers. I think in myeloma, the question would be, what are the risks and benefits of a transplant in the setting where you have to make some considerations for not being able to give, transfusional support. Unlike other diseases, autologous transplants in myeloma are not curative intent. They are a tool that we use to help to deepen and stabilize remissions, to give people longer periods of disease control and to improve overall survival. But it is a tool that's part of a number of tools that we have to sort of be able to optimize disease outcomes. So I really think the decision on whether or not to pursue the autologous transplant in somebody wherein you may have a higher risk than you do in somebody who is able to receive transfusions. Because the good thing about transplants in myeloma is we've been able to reduce the risk associated with them to a very significant degree. We don't deal with a lot of transplant-related mortality, but there are circumstances that may increase those risks. And so I think the question of where that equation lies may be a little bit different in somebody where you have to, go through the transplant in different circumstances. So it may not be the right fit for every Jehovah's Witness, and it kind of depends on the circumstance. And
Dr. Nuka, thank you. Dr. Nuka, is your center one that will or does perform bloodless transplants?
We're one of the centers that do bloodless transplants. Right now, as we speak, there's a patient from Texas that came in and receiving a bloodless transplant. So I completely agree with Dr. Forsberg, how he laid out, it's because we could do a transplant does not mean that everybody needs a transplant. But there are certain patient populations who are Jehovah's Witness, who you feel would get the best benefit if they go for a transplant based on all the data put together. And absolutely, those patients, we offer them the bloodless transplants. The centers that do or handful. I know for certain there's one in Pittsburgh, Cedars-Sinai does, Mount Sinai does, we do, and we probably do around 5 a year or so. And the prior data that was published in JCO shows that there's a 5% risk of transplant-related mortality with a autologous stem cell transplant within the first 30 days. And we felt that is too high. So we published at first 25 patients that we did a bloodless transplant on with 0% transplant-related mortality. And all we did was trying to maximize the benefits or maximize the supportive care through the process. And it should not be the uniform process that we do it for everyone. We minimize the blood draws, like probably two times a week. rather than doing it every single day. For all the transplant patients, we bump up their hemoglobins with ESAs prior to the transplant all the way up to 12s, 13s, so that we are starting high. Those are all the things that we take into consideration, make it more meaningful for us to do this in the most safest way. And knock on wood, we didn't lose any patients so far.
That's great. So great information. I think what we've learned is that it is possible for patients with multiple myeloma who are Jehovah's Witnesses and or others who won't accept blood product transfusions to be treated with the standard of care therapy. In some cases, one can hope for actually an improvement in the blood counts with treatment. So certainly is highly recommended to treat them with the standard therapies that we have available. And consideration for bloodless transplants done at specialized centers can be beneficial and should definitely, it sounds like, be considered. So thank you.